It's a little dangerous to put a talk on standards in a warm room right after lunch. So I hope I can keep you all awake, and oddly enough, I get rather passionate about this topic. I didn't start off thinking ever that I would do something in standards. My first postdoc was with the National Institutes of Health in Phoenix, Arizona, where I worked with the Indians. And I ended up then, after that, coming to Japan and working in Japan for 2 years. And I worked in France for a year, and went back and spent 9 years at a clinical research organization. And that's what made me realize that we needed standards, because as everyone asked for data in a totally different format, it was impossible to create any efficiencies in what we did. So we started CDIS in 1997, and I'll share some of that with you today. But I'm going to first start off with this slide. This is a little remedial for a lot of you, but it's an example that we used in some of the early days of CDIS, because people hear you say standards and they think, oh, quality standards or something else other than data standards. So we wanted to explain really what we're talking about. And if I give you this data set, can you tell what I'm talking about? So you've got an event that began and ended, and you've got some times in there. DSF. How about that one? So this was put together by Dr. Christensen to explain why metadata is important, because these scientists got the data in units that they didn't anticipate. So they made a mistake. Instead of SI units, these were imperial units, and it caused the crash of a rather expensive Mars space orbiter because of the misunderstanding of metadata. So one of the drivers behind creating standards was to create some metadata standards so everybody could see data sets and know what they received, including people at the regulatory agencies that review data to approve new pharmaceuticals. But it can happen in any field, and it reminds me of when my teacher used to tell me you need to make sure you've got your units on every napkin when you do. So this is what we're talking about when we talk about data standards. And to be honest, when we started CDIS, we started with metadata because once you start getting into terminologies and such, it becomes very, very difficult to create standards. But the metadata is not quite as hard. So why do we need standards? Because we want to make sure that the meaning is clear when people receive data. We want to make sure that we maintain the quality of that data. Provenance has become a big word in the United States right now about how do we keep provenance when we exchange data and we know where it came from, and when we send it, does it retain the traceability that we had from the beginning? Can we tell what happened to that data if it's changed? And so that's important. Communication, we find that if you have standards, teams actually communicate better. And we've done some studies that show that standards can save significant time and money. So we're working on a project in the IMI, Innovative Medicines Initiative, and they asked us to put together a starter pack on standards. And we said we really need to talk about what constitutes a good standard. When you go out and pick a standard, everybody has this joke about how many standards there are out there, but I contend that there aren't very many good ones, and a lot of them are redundant. So when you are looking for a good standard, you want one that is used for that intended purpose. A lot of times people go, oh, just use this standard. Well, if it's not suited to that purpose, it's not what you want. And you want something that's robust in terms of its development. You want to go with a recognized standards development organization and a consensus-based process. Ideally, it's a global consensus-based process. I like to see standards that are open and free, and there are some that are not, and they really harmed the field when they came out and started charging royalties for standards. So open and freely available. If the standards are harmonized and they're complementary to others instead of competing or redundant, we we don't need a whole lot of redundant standards, and you need to make sure they're sustainable, that they have a program that they're going to be around tomorrow, that they're maintained, and that they're supported by educational courses. So I'm going to go back a little bit to what Dr. Friedman talked about in terms of a learning health system. A learning health system should ideally support all types of learning. Learning in terms of quality, did we do work that had high quality results in the healthcare industry, and how do we measure that? We want it to support research and public health and all kinds of things like that, like Dr. Friedman's outbreak example. We want to make sure that standards can support big data, although big data is a lot of times a mining exercise in trying to find signals that then have to be proven by more controlled studies. So we certainly want standards that can support the collection of high quality research data for data science. And with that in mind, you see up here on the top left, Dr. Friedman's circle that he showed several times this morning in his slides with different examples. And we have a group in the US that we started, and there are a few participants from Europe on this. It's called the Essential Standards to Enable Learning Initiative. And we've been working with several people and in groups to try to take that circle and turn it into how can we really apply this cycle to different projects. And we'll be coming out with a framework and some ways to see whether your examples fit a learning health system. So I hope that we can get that out sometime next month. So how can standards facilitate a learning health system? I'm going to talk about a few standards, and then I'm going to give you an example of how we can put them together and that they work in a complementary manner. And there are other standards that will work. There are other ways to do this. So mine is just really an example of one potential way that standards can support a learning health system. And because it's the area that I'm most familiar with, I'm going to talk about research. So CETIS is a standards development organization. I didn't even know what that was in 1997, and somebody was meeting with us and said, why don't you have standards in your industry? I've started working with some research sites, and every sponsor asked for the data in a different format, and I can't do that. So they said, why don't you have EDI? And I said, what is EDI? And they go, well, it's electronic data interchange, and this is coming from the big 6 chemical companies around the world, like Shell and Chevron and those companies, and saying, well, we can exchange data because we have EDI. So that's where this guy came from, and he said, why don't you start this in the pharmaceutical and research industry? So that's when we started CETIS. It was actually a nonprofit starting in 2000, and before that we were just a group of volunteers. So this was truly a grassroots effort. Now the standards are loaded and downloaded from our website in over 90 countries around the world, and we're considered a liaison A with ISO TC215. And TC215 is the technical committee that works with healthcare standards. I know some of you from those meetings, and this is liaison A means that we can take our standards in on the fast track, but we chose not to do that because we wanted people to really understand the standards that we're talking about. And one of the standards that we took there is called our bridge model. And that's a model that harmonizes all of our clinical research standards. And we thought, well, if we take the bridge model to ISO, then all of the standards will be approved. And by getting an ISO approval, you've also got a CEN approval, which is what's needed in Europe for the European standards. And we work with what's called the Standards Joint Initiative Council for International Harmonization of Standards. So we're trying to make our standards complementary and work with each other, even though we've got different standards groups. And that little symbol is our Joint Initiative Council symbol, which now has 7 different SDOs in it that work together. CETIS itself has a suite of harmonized standards, and we concentrate on the clinical research area. So we don't want to do healthcare standards other than we want to link to those, and we don't want to be redundant. And we want to have standards that enable data sharing and aggregation of that data, and that support all the different types of research. So our standards can be used in outcomes research, clinical research, and some of you know Dannon Yogurt. Dannon Yogurt is using our standards for nutrition research right now. So they're very applicable to different types of research. And we do have a link with healthcare standards. We work with ING, Integrating the Healthcare Enterprise, and Health Level 7. And the bridge model, it took 7 years, but I think next month it will be an international standard. So I'm going to talk to you just about like 3 standards today that are specific to what my example is for the learning healthcare system. And one of these is called CDASH, which was named after Dr. Woodcock said, I'm sure you'll find up with a catchy acronym for this, and we wanted to do things faster. We wanted to do a standard that would work for data collection. So this actually is a standard that was developed around the world in all of the ICH countries, Japan, Europe, and the US. We got thousands of comments on this standard. It's a consensus-based standard, and it has approximately 200 core data elements in 18 different domains like demographics and adverse events, concomitant medications. So it's a core data set that cuts across all clinical research studies and is required by regulations around the world. And it was developed to actually have questions on case report forms and the answers that go with those. It's complemented by controlled terminology that's open and free, and it's housed by the National Cancer Institute in the U.S. because they have a very nice system for supporting that, and it's their enterprise vocabulary services. So you can Google on that and find those terminology elements. And CDASH maps into tables. So CDASH is an individual patient data that maps into tables that are given to FDA, and now PMDA will be requiring those by 2016. So this is going to be a regulatory requirement for any information that goes to FDA or PMDA to support the approval of new products. ODM, I know Brendan's going to talk a little bit about using ODM, but ODM is XML technology. So in other words, if you collect the CDASH data, you can carry it in an XML bucket, if you will. It's a holder, it's a carrier for that data, for case report form data. And it carries a complete audit trail, which is our requirement. It's kind of like the HIPAA for research. It's called 21 CFR 11. It's a regulation that says that you have to have certain information. So if the data are collected and they're received downstream, that you can trust those data, and it carries the audit trail saying, when was it collected, who was logged in when it was collected, was it changed, if so, by whom, and when, and why. So that's the audit trail, and it is a really good archive standard because you don't have to archive the system. You can archive the data and go back and pick it up by another system that's happening years later, since your systems will go out of vote before the ODM does. So it's a very good archive standard, and it allows the exchange of data between different kinds of technologies, so like electronic diaries or patient-reported outcomes, and into systems and between different parties. So it's very handy. And that shot over there on the right-hand side is an example of a case report form that's rendered in ODM using CDASH elements for demographics. And you can have it look whatever way you want, but the elements are the same, and in the back behind those, the format's the same, so it can be readily exchanged. This is just a picture of the ODM with how you carry the audit trail within that. And so we're talking about using that for provenance as well. So all of these standards, and I'm not going to go through them all with you today, but they go from protocol through data collection to tables and analyses to reporting or submission. And all of those are harmonized together with this model called the bridge model. And in between, I guess kids that could use a pointer. So protocol, data collection, tables, and analyses, and submission. And the send is just what's preclinical data. It's for animal data. And we have controlled terminology, and now we're working on therapeutic area standards. And these are all harmonized together so that one standard doesn't break another, and they feed from the beginning to the end. So what are we doing with that? This is a picture from a presentation made by a woman from PMDA who spoke at a couple of our conferences, and you can see that all the data coming into PMDA is coming in the CDISC format. And so they will be requiring SDTM and ATOM analysis data sets and submissions between now and 2016. They want the controlled terminology, and they want it in English. And they are encouraging the use of CDASH because if you collect the data in CDASH, it flows downstream into SDTM, and it doesn't require a whole lot of mapping. And it means that you can start a study up in 70 to 90% less time if you use CDASH from the beginning. So it's not just PMDA who is requiring SDTM and ATOM and encouraging CDASH, but this is a talk that was given by a statistical reviewer from the US FDA who said, I wish I'd known about CDASH a long time ago, because if people would just use CDASH, I would be able to get higher quality data and I could see the traceability. So he is promoting this, and he asked if he could come and give this talk at our Interchange. So I'm going to give you a couple more examples of how these are being used. This is a slide from Tohoku, who works in the data management at the Data Center for the Translational Research Informatics Institute in Kobe. And they have funding that they give to universities around Japan to do research studies, and they require that all the data come into their system in CDASH format. So this is the institute in Kobe, and they are working with CDISC standards and have built their system around CDISC standards. So they not only work with research, but primarily academic research and not research that goes to for the pharmaceutical companies. So we have standards that support research, and I'm going to talk for the rest of my talk about what we can do with those standards and research standards to link back into the healthcare systems. So this is a slide that just shows what's going on in most cases now with research in healthcare is the healthcare data are collected now more and more in electronic health records as those are being encouraged, but then the data are taken out, and Leonard Bain calls it swivel chair technology, because somebody enters the data into the EHR and then they go around and they enter the same data into an electronic data capture system for research. So not only is it inefficient, but it asks for problems because you can re-enter the data, you can make mistakes, and it's really very inefficient to do this re-entry and transcription. This is a slide that Ron and I put together when we started CDISC in 1997, and it was our vision of how can we connect healthcare and medical research through using electronic source data and just take the data from EHRs into research case report forms. And this is possible. It's not being done very much. It's not really clear why it's not being done a lot, but I had a call the other day from FDA that said, why isn't this happening? What can we do to encourage it? So I think that now that EHRs are becoming more and more widespread, we're going to try to do something to encourage more use of those for research. And this is a slide that Lana put together that I liked that he put recently. And if you want to see the whole narrated video, it's on our website. But Lana Bain is the ex-CIO at Duke University, and I think it's going ahead without me, isn't it? So this is about a profile that Lana put together working with integrating the healthcare enterprise. It's retrieve form for data capture. So you have an electronic health record and your electronic data capture system, and you want to get data out of one and put it into the other, and you'd really rather not do it with swivel chair technology but rather take the form that's here and pull it into this view and have some of these elements already pre-populated, which is possible. So that's retrieve form for data capture, and the opportunity that this affords is that now that you have EHRs and you can use integrating healthcare enterprise profiles like RFD, you can get CDASH out in ODM for research. We can actually make this happen and integrate the healthcare and the research. And you heard some of the talks this morning, and hopefully Dr. Kimura will talk about this a little bit more. This is something that they're doing in Japan now to get standard data out of an EHR, as opposed to what is happening in the US with some continuity of care documents. So this is a slide that I got from my friend Kiyo Takeuchi, and this is about SS Mix and how they're actually using it on a database of medical information with 10 million patients to look at safety. And that's the Sentinel project in Japan. So I'm going to close my talk and hope you all have a few questions, and just say, can we successfully apply standards in a complementary way, standards from different organizations that are intended for different purposes in a harmonized, complementary way to facilitate a learning health system? And another consideration, and I think it's something that's important to discuss as we talk about what is a learning health system, is that I hear more and more that people are trying to save this data and not share it. And we have 3 projects that we're doing with the Innovative Medicines Initiative in Europe. And Dr. Michelle Goldman, who was their executive director for until just recently, now that they're starting IMI2, he had to step down, but he said, what can we do to tell people if they're doing data sharing, they should use standards to make sure that it's responsibly done. And so we ended up with a perspective in the New England Journal, and it's interesting how we had to explain this to them because they really didn't understand what we meant by standards, and yet they published a number of papers on data sharing. So a lot of people talk about data sharing and they forget about making sure that when you share data, you retain that integrity and that you do it in an appropriate way. So I have some copies of this paper because it's not one I can send out electronically, and if you want them, I have them for afterwards, you can take them home with you. And I will close with this slide, which is CDISC has had a presence in Japan since 2002. We have a very active group called the Japan CDISC Coordinating Committee, and it's actually been interesting to see it grow. So the original person who headed up this group just retired from GlaxoSmithKline and went back to his home and fishing village in the south of Japan, and it's turned over to a new leader now, Toyoda-san, and we have about 10 people who put on a meeting every year, and this one is going to be in June, where we'll have talks by an academic because the PMDA wants to stress quality, and they want somebody to come and talk from academia about that. We'll have speakers from FDA and PMDA, and we'll have training courses on some of these standards, so that's an opportunity that I wanted to share with you.